This is The Rounds Table. Welcome back, listeners. This is going to be a solo episode. I'm going to be discussing the trial entitled Spironolactone versus Amiloride for resistant hypertension, a randomized trial, published in JAMA in the spring of 2025. Okay, so let's start by setting the stage. Resistant hypertension is defined as blood pressure that remains above target despite, generally, the use of 3 or more antihypertensives, and one of them has to be a diuretic. It can also be defined as just needing 4 medications to control blood pressure. It's not super common. It affects maybe 10% of hypertensive patients, and it of course carries a worse prognosis than individuals who do not have resistant hypertension. Spironolactone is generally the preferred add-on treatment, but it can cause a number of adverse events. Probably the one listeners will be most familiar with is hyperkalemia, which of course can be life-threatening. Another side effect, which maybe not everyone's aware of, is that it also has anti-androgenic side effects, so like gynecomastia. And you could imagine if you were a 50-year-old man with resistant hypertension and you get started on spironolactone and then you develop gynecomastia, I would probably want to stop that drug. So are there other options? Well, one, as the title of this trial suggests, is Amiloride. It's a potassium-sparing diuretic, so it too can cause hyperkalemia. And there are results from the Pathway 2 sub-study which suggested it might be almost as effective as spironolactone. However, that was a sub-study of a prior trial, so the authors here wanted to compare head-to-head whether or not Amiloride is not worse than spironolactone. Statistically, this would be a non-inferiority trial. So what did the study look like? It was a multi-center randomized trial conducted in 14 tertiary care hospitals in South Korea. The included participants were aged 19 to 75. They had to have resistant hypertension, defined as a systolic blood pressure equal to or above 130 millimeters of mercury, despite triple therapy. And generally that was, renin-angiotensin inhibitor, calcium channel blocker, and a thiazide-like diuretic. The trial included a run-in phase where all eligible patients were switched to a 4-dose triple combination of amlodipine, olmesartan, hydrochlorothiazide for 4 weeks. This is a smart idea. This ensures that everyone is on the same drugs at baseline. If you want to learn more about run-in studies, that was actually the focus of my master's thesis. So I will indeed include a couple links to that in the show notes in case anyone is super interested, although I doubt anyone will be. Okay, back to the study. So individuals were randomized 1-to-1 to either spironolactone, 12.5 milligrams once a day. For listeners who are unfamiliar with spironolactone, that's a very low dose, or Amiloride, 5 milligrams per day. And it was stratified by age and sex. Patients had blood pressure measurements, so office blood pressure was measured by trained nurses using validated devices, and they took the mean of 3 readings. And then there was also home BP recordings that were done twice daily for 7 days before each visit. The study assessed adherence using pill counts. So at the end of each few weeks, the patients would bring in their pill containers and the team would count to see, okay, how many pills were actually taken. The primary endpoint here was a change in home systolic blood pressure from baseline to week 12. There was a number of secondary outcomes. And then the stats, I won't bore you to death, but as mentioned, it's a non-inferiority trial. The margin they set was 4.5 millimeters of mercury. So if, for example, spironolactone reduces your blood pressure by 10 minus 4.5, ooh, mental math. Okay, that's 5.5. If Amiloride didn't achieve at least 5.5, then you would call that non-inferior. Okay, hope that helps. Let's go on to the results. So they assessed 190 patients for inclusion into the trial. 26 were excluded for various reasons. 164 patients entered the run-in period, that 4-week run-in period. After that, 46 more people were excluded. The most common reason why they were excluded is because 37 of the 46 actually achieved really good blood pressure control with that combination drug. So they, of course, wouldn't meet eligibility anymore. So 118 were randomized, 58 got Amiloride, and 60 got spironolactone. In both groups, 2 patients were essentially lost to follow-up. So what did the included patients look like? Average age was 53. 71% were male, which makes sense because high blood pressure is far more common in men compared to women. 50% had dyslipidemia. 30% had type 2 diabetes. About 7% had heart failure. The baseline blood pressure in the office was essentially the same in the two groups at 145 systolic, and the 24-hour blood pressure from home was also similar between the two groups. Okay, so what did they find? Was Amiloride not worse than spironolactone? All right, so at 12, the mean home systolic blood pressure measurements were reduced by 14 millimeters of mercury in the Amiloride group compared to 15 millimeters of mercury in the spironolactone group. As a result, Amiloride is not inferior to spironolactone. It's not worse than spironolactone. And more simply, this isn't statistically perfect, but they essentially achieved the same reduction in blood pressure. You could estimate it of saying both these drugs reduce blood pressure by about 14 millimeters of mercury. There was one case of hyperkalemia that led to treatment discontinuation, but that was in the Amiloride group. There was no cases of gynecomastia in either group, but maybe 12 weeks is just too short of a time period. And then the overall drug adherence for both groups was excellent, with most achieving 80%. So what are the limitations of the study? It's small. It's a short follow-up study. 12 weeks is such a short period of time. I wish their follow-up was 12 months. But I get it. It is a much harder study to pull off 1 year of follow-up. How come? People drop out, people stop their medication, etc., etc. So really, this study only tells us that for the next 12 weeks, Amiloride is probably not going to be worse than spironolactone. And then, another limitation, not a big one, is that they used relatively low doses of spironolactone. So, will this apply to patients on a much higher dose of spironolactone, like 50 milligrams? Not sure. Another important limitation, this study didn't include patients with chronic kidney disease, so unknown if the results apply to that population. So there you have it. This is, I thought, just a really nice pragmatic trial answering a question that comes up often clinically, at least in internal medicine. I totally get the fact that resistant hypertension overall isn't super common, but in the internal medicine world, this is definitely something we're thinking about seeing in clinic or in hospital. And this provides some, at least initial data, that Amiloride is probably not going to be worse than spironolactone. I think this is most relevant, again, for that 50-year-old man who probably does not want to develop gynecomastia from the spironolactone that you are about to prescribe. So there you have it. Very curious to hear from our listeners that are card-carrying high blood pressure experts and or see people much more than I do in outpatient clinic, how you make sense of these results. Good stuff on our end. Let's see. Not too much. Trial Files is still, alive and kicking and growing. So for anyone who's interested, we just launched a hematology oncology Trial Files. There's also an allergy and immunology Trial Files. And as of the time that this comes out, there's also a critical care Trial Files. So lots of links to those in the notes below. If you enjoyed the episode, write us a review. We find that so helpful. We appreciate the feedback, and it's a really great way for us to improve and to expand our listenership. All right, that's it, and stay well.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.